radiates, there's chest radiating to the neck and to the arm, typically the left arm. Remember, diabetics, it can be different. It can be kind of just to the jaw or relatively asymptomatic. Troponin levels are elevated, but again, when you see that EKG, you should not be waiting to make a decision based on a troponin level. Those are criteria: ST segment elevations greater than 1 millimeter in 2 or more contiguous leads. Treatment: this is the person you want to get up to the cath lab right away. If you're working in a situation or in a hospital where they don't have a catheterization lab and you need to transfer them, you can give thrombolytic therapy, TPA, and then still transfer them because they're going to need most likely a definitive procedure. TPA is not going to dissolve all the clots. Remember, I don't know if you guys did like the pathophysiology of what an MI is, but usually there's chronic narrowing, and then there's a plaque that ruptures, and you get platelet aggregation, and you get a total occlusion. So the TPA is going to help break up that clot, but if there's a plaque there, a cholesterol plaque or fatty deposition, it's not going to really do anything for that. So even if you give somebody TPA and maybe their clot opens, they're still going to need a definitive procedure. Also, antiplatelet therapy, aspirin, beta blocker, and definitive anticoagulation. So this is a bad EKG. You definitely don't want this EKG. Okay, so just kind of in summary, it's 4 o'clock now. I want to be respectful of time. We went over about 5 or 6 cases here, from the benign costochondritis to the deadly, an ST elevation MI. When you see somebody that presents with atraumatic chest pain, consider your differential diagnosis. Most of these patients are going to come in and they're going to get an EKG, a chest x-ray, get hooked to a monitor so that you can then evaluate whether they need something emergently, or like that person with the small pneumothorax, if you can watch them for 12 or 24 hours and get some serial x-rays. The things that you don't want to do is send somebody home that has a bad condition. Not only because they're going to do poorly, but that's not what you're trying to do. Now, medicine is not a perfect science, and over your lengthy careers in the future, you will make some medical errors. But you should always, at the end of a case, as you're leaving your shift that day or you're leaving the hospital, you need to at least feel like you did everything you needed to do for that patient in front of you. When you are taking care of a person who has a potential emergency, and there's a lot of stuff going on around you, your singular focus should be right on that patient. You need to be able to kind of avoid any unnecessary interruptions. Your phone should not be, you should not be on your phone. You should not be having 2 conversations. Your focus needs to be on that patient because these are life or death situations. And you need to be able to live with yourself at the end of your shift. And you don't want to make unnecessary mistakes. Nobody's perfect. You can make mistakes, but you at least want to make sure that you've kind of given that patient a fighting chance and given them your best effort. All right, so we'll stop here. Tomorrow we can do different stuff. We can, I don't know, I'll think about, I'll see what, any preferences? We got peds, ortho, trauma, abdominal pain. Do ortho tomorrow. Ortho's a fun one. Ortho's a fun one because usually I get people up here and muck around with them a little bit. So we'll do some adult and pediatric ortho tomorrow. And there's a lot of x-rays, so you get a chance to see that.
Do we get access to your presentation?
I think so. Ilshad, I don't know if he stepped out. Yeah, Ilshad has them all, so hopefully he'll share that with you or put it on some kind of drive or something like that.
Could you put it against a white background?
Yeah, I screwed this up. This was I think he changed a bunch of, I think he changed the ones that I got going forward. So
Okay,
yeah, they'll look better. I didn't really realize that when I'm building these on my computer in front of me. They're very easy to see, but in a setting like this, they're not so easy. I think the next one's in a different formatting. So, all right, good. Now you guys gonna study tonight, or what's going on? Yeah, yeah, nonstop studying. All right.